Un'intera sessione dell'11° congresso nazionale della SIOMS è stata dedicata alla relazione fra patologie gastrointestinali e osso. La dottoressa Guanabens si è concentrata sul fegato e su come le patologie epatiche influiscono sul metabolismo dell'osso. Dr. Guanabens, which are the connection between liver and bone metabolism? Could you please explain to us?
Yes, liver patients have with frequency bone diseases, mainly osteoporosis. And what I would like to say is that clinicians don't pay care to the bone disease of liver patients, and that's very damaging because you can prevent. And when patients arrive at transplantation, sometimes they have fractures and they will go to a transplantation, and that's very bad for the bones.
You say liver diseases, but which are exactly the liver diseases that more affect the bone metabolism?
Well, all liver diseases may affect bone, but the most important are cholestatic liver diseases, which are primary biliary cirrhosis and primary sclerosing cholangitis. Also hemochromatosis, alcoholic liver diseases, so almost all of them, but some more than the others.
And could you please explain the mechanism of action of the damage?
Well, there are a number of contributory factors, but in cholestasis the main mechanism is the retention of the products from the cholestasis. It means bilirubin, bile acids, and probably a decrease in growth factors. Also, it depends on the etiology of the liver disease. If we are talking about hemochromatosis, it's iron has a direct effect on bone cells. So there are a number of contributory factors. Also, in addition to the retained substances, in addition to the toxic effects, there is an increase in some stages, there is an increase in resorption, probably because of hyperparathyroidism secondary to vitamin D deficiency. And in addition, poor nutrition, low levels of vitamin D. So it's not only one mechanism, there are a lot of mechanisms, one more important than the other.
And which type of damages are for the
damage,
bone?
The main damage in bone is low bone formation. The retained substances of cholestasis, toxics on bone cells, they induce low bone formation. And that's the main mechanism and toxic effect.
And which are the main risk factors for this type of patients?
Yes, if you study the main clinical risk factors for developing osteoporosis, you have that in cholestatic liver diseases, the main risk factors are the severity of the liver disease, duration, advanced histological stage. In other diseases, for example, like primary sclerosing cholangitis, the duration of the bowel disease, and of course general conditions for osteoporosis such as advanced age, the presence of fractures. So if you take into account all these mechanisms, all these risk factors, you can identify better the patients who will have a worse osteoporosis.
And at the end, what to do in this patient to prevent bone damages?
Of course. In all the liver diseases, to control the liver disease. So I mean to have an accurate disease evolution. In addition to this, you must identify patients with low vitamin D and with a low calcium intake. And of course, if you have patients with osteoporosis or with a very low bone mass, you can add drugs that have been demonstrated to be efficacious, more or less, in osteoporosis in these patients.
And which type of drugs exactly?
The drugs that have been mostly analyzed at present are bisphosphonates. I mean, from alendronate in pre-transplant, on cholestatic liver disease, to ivandronate, and after liver transplantation to zoledronic acid. I mean, all kinds of bisphosphonates.